morning, everyone, and welcome to Internal Medicine Grand Rounds here at University of Louisville. It's my pleasure this morning to introduce that we're actually having our Richard Redinger lecture, and this is, of course, in honor of one of our former internal medicine chairs who was a gastroenterologist. And so I'll be introducing the introducer of the introducer, and that is Dr. Chris Kruger, who is currently a professor of medicine and chief of our clinical operations here at the University of Louisville. As in her role for vice chair for clinical operations, she's helping me redesign all sorts of things, and she's really been a valuable person to me in the last 7 months. She is originally from Florida State University, where she went to medical school, followed by Medical University of South Carolina Medical Center for residency and fellowship. And she's been on our faculty for a bit of a while now, I think since 2000. And we really appreciate her leadership, and in this case, her introduction of our named lecture. Dr. Kruger?
Thanks, Kim. So I met Dr. Redinger, you're right, in 2000, and he had been here since the mid-'80s. So he actually probably still holds the record of being the longest tenured chair in the United States for the Department of Medicine. He is a bile acid researcher, and his vision and his tenacity for education and for scholarship led him to grow the Department of Medicine from a small clinical department into a premier research department. So because of Dr. Redinger, we have Dr. Batnagar, Dr. Boley, Dr. McLean, and Dr. Donald Miller, all premier researchers, and many, many, many others. So we thank Dr. Redinger and we honor him today. And I'm going to let one of his hired researchers introduce our lecture speaker for today. So Dr. McLean.
Thanks, Chris. We're playing musical chairs here today. It's a pleasure to introduce our speaker today, Dr. Ashwani Singal. So for the Redinger lectureship, we always try and get a world-recognized liver specialist, and Dr. Singal fits that definition perfectly. So he went to medical school and did his initial training in India. Actually, he was there with Dr. Moshe Gundam. He came to the United States then and did his residency in New York, his GI fellowship in Galveston, and then went to the Mayo Clinic where he did his transplant hepatology training. He then joined the staff at UAB, where he rose through the ranks as associate professor, and he directed their porphyria program. He then went to the University of South Dakota, Sanford, and he has many leadership roles there. He also has many leadership roles in the FAASLD, and it's a pleasure to have him here today talking about alcohol-associated liver disease. Dr. Singal.
Thank you, Dr. McLean, and Dr. Kruger and Dr. Williams for sparing your time and this opportunity. And it's really a privilege to talk to the Department of Medicine and Division of Gastroenterology Hepatology on the topic alcohol-associated liver disease. So let me share my slides. Okay, can everybody see?
Yeah, looks good.
Okay.
Looking great.
Okay, so the reason I chose this topic is obviously me and many others like Dr. McLean and many in his division have interest on this condition. And also I think it's one of the most common liver diseases, especially requiring transplant, and especially since the COVID came in, this disease has really taken its toll and has really gone up, especially in the younger population, 30s and 40s, ending up with end-stage and advanced liver disease. It's difficult to cover everything in 40 minutes, which I think I will spend on presentation. focus on mostly the salient features of the disease, and we'll spend a little bit what we did as a translational research, and also what I learned during my visit last week, certain things which were new to me, and it was quite a learning. So I'll have a couple of slides on those. So with that background, I have no disclosures relevant to the talk. Out of these mentioned here, none of them is related to the presentation I'm giving today. So over the next 40 minutes, we will talk about, so we'll bring a concept of an early ALD, alcohol-associated liver disease, and then how we can screen and assess fibrosis risk in this population. And then an advanced disease, focusing mostly on alcoholic hepatitis. I will not talk much about cirrhosis, which I think is a more or less standard treatment, whether it is transplant or out of transplant. So mostly on alcoholic hepatitis, especially about early liver transplant. And then some of the updates on emerging therapies, and then more and more promoted model of care, in a multidisciplinary integrated care model to tackle not only the liver disease, but also the alcohol use disorder. I think we would all agree that this is important and needed to manage the patients. I would keep the talk and presentation mostly clinical, given it is medical grand rounds, but then in between we will share some of the important translational data which would be relevant to the presentation. So this is the concept with the early disease is something when the patients present with asymptomatic, either with fatty liver. They may have steatohepatitis, but they don't have symptoms or jaundice, and the fibrosis may be up to stage 2. And when the fibrosis extends beyond to even cirrhosis, which could be compensated or decompensated, and a unique condition of symptomatic alcoholic hepatitis with jaundice, I think the threshold for suspecting alcoholic hepatitis in decompensated cirrhosis due to alcohol should be pretty low. And we'll talk about how to make the diagnosis, and then complications like hepatocellular carcinoma, that becomes more advanced liver disease. So starting with the early liver disease, so the first half of the talk, or first 1/3 of the talk, and the later 2/3 of the talk would be an advanced disease. So starting with a clinical case, a 36-year-old female. She was seen in an alcohol rehabilitation treatment unit, and then on screening was found to have some evidence of liver disease, normal synthetic function, normal platelets, elevated liver enzymes, AST more than ALT, quite typical of alcohol-associated liver disease. Other causes were negative. Ultrasound showed enlarged steatotic liver. So I think it is important, and everybody would agree that it's important to diagnose a disease earlier before it gets into an advanced disease, whether it any kind of liver disease. Unfortunately, the alcohol-associated liver disease, by the time they present for several reasons, which could be patient-centered or the disease-centered, it kind of presents when it is already advanced. And there are many, many studies showing that kind of data. Not only it presents at an advanced stage, but once it presents, even if it presents at an earlier stage, the progression, if the risk factor is not controlled and the patient is not recognized and treated early, it can progress pretty fast compared to other liver diseases to a more advanced stage. So it makes perfect rationale for diagnosing and recognizing this disease early on. And obviously, you cannot screen everybody or all the population. So focusing on those who have the risk factor for developing alcohol-associated liver disease, and how do we do that, is to screen for a harmful alcohol use, which we typically define as 2 or more drinks in a female per day, or 3 or more drinks per day in a male, or 7 per week and 14 per week respectively. That is the definition given by NIH and AAA for harmful alcohol use. In a clinic, I think the audit C, or alcohol use disorder identification test, it's a brief version of a full audit test, which is a 10-item questionnaire, each reported by the patient on a scale from 0 to 4, but a shorter version of 3 questions, which is listed over here, in about 30 seconds to 40 seconds, can quickly tell you how bad the patient has alcohol problem. For example, out of a total score of 12, anybody with a score of 3 or more in a female and 4 or more in a male would tell you that it is a risky behavior which could end up in a liver organ damage or any other organ damage. And as the number goes up, the severity of alcohol use disorder increases. Because the score is kind of based on number of drinks, so it is important what is a typical drink, because patients may say different things and may have their own definition of a drink, but practical definition of a drink, which is translated into the harm based on this audit score, is 1 can of beer, which is 5% alcohol, 1 glass of wine, which is 7% of alcohol, or 7 to 12%, and then hard liquor, which is about an ounce and a half. And it all translates into about 15 grams of alcohol in 1 drink. And so knowing that is important, because a patient may be actually thinking that 3 ounces of alcohol is actually 1 drink, which is not the case. It becomes actually 2 drinks. So it becomes really important to gauge not only the number of drinks, but also the amount in each drink, to gauge the amount of alcohol the patient is taking. And as we know that the self-reporting of alcohol use by the patients may not always be accurate due to recall bias, or they may not be giving you the correct information. In some cases, biomarkers which are emerging based on alcohol metabolism are gaining importance and clinical relevance. They are commercially available now, especially ethylene glucuronide, which is a metabolite of alcohol, and so is phosphatidyl ethanol, which is also another metabolite of alcohol, which a non-oxidative metabolism, which is 2% of alcohol, but gives you enough information of past alcohol use for up to 3 to 7 days with ETG, and maybe up to 3 weeks with PET. The role and clinical practice use of these biomarkers is not very uniform across centers and across providers, because they are emerging, and also the data is pretty difficult sometimes could be to relate to the actual drink. And we have seen in clinical practice the patient keeps denying, but the markers are positive, especially with the ETG, with exogenous alcohol use for say cough syrups and from sanitizers and all, can result in false positive testing. It may not be the case with PET testing. When it comes to the transplant candidates, whether PET testing is beneficial or not, and I think Dr. Jofflin from here has an important study in the literature, which was recently published last year, where she showed that the PET positivity is associated with unfavorable wait list outcomes. So there are more delistings, more denials for transplantation. I think there are no studies whether that kind of approach improves the outcomes after transplantation in terms of reducing relapse post-transplant. I think those kind of studies are really needed to make PET testing kind of a uniform across transplant centers. And we can have that kind of data, they'll be really making a recommendation to have hepatitis testing among patients who are either listed or being considered for transplantation. So when you have an early disease like the patient we just saw, I think it becomes important whether the patient has a liver disease once you identify a risk factor. So the guidelines, most organizations would mention that minimum testing which is required is the liver test, the platelet count, and the liver imaging to not only tell you what kind of patient has the disease, early disease or late disease, but also to some extent will tell you what kind of fibrosis risk the patient has, especially the FIB4, and I will show you that in the next few slides. So determination of the risk of fibrosis, as we just like a few slides ago, we saw the early versus late disease depends on the degree of fibrosis. Like any other disease, NASH or hepatitis C becomes relevant. So patients who have harmful alcohol use and are prone to develop liver disease, early disease, the advancement of the disease doesn't happen in everybody. Only about 10% will end up in advanced cirrhosis, that kind of advanced compensated or decompensated cirrhosis. So certainly there are more factors or disease confounders which make somebody prone to develop an advanced disease or cirrhosis. When we talk about the disease, a unique condition, as we heard, called alcoholic hepatitis, and disease-oriented, I think, in my mind, presence of alcoholic hepatitis, even if it is in the asymptomatic stage on a biopsy, makes somebody's disease progress much faster to develop cirrhosis and much higher. Now, for example, it only 5 to 10% here and 20 to 20. It's about 4 to 5 times higher risk of going into cirrhosis if they have inflammation, steatohepatitis on the biopsy. And there's certain other factors, and that's why it becomes really important in the clinical unmet need. Do we can biopsy everybody with an early disease? Do we have some kind of non-invasive test that somebody comes with an early disease who is asymptomatic, and we can say this patient has a high risk because the non-invasive testing shows that there is underlying steatohepatitis in a more accurate fashion. I'll show you some of the data which is emerging. Some of the other factors, like host factors, which make you at a higher risk to develop cirrhosis, like we know that females are more susceptible, and that's why the threshold for drinking, harmful drinking, is lower in females. Certain comorbidities like obesity and chronic hepatitis B and C, genetic polymorphisms like PNPLA3, TM6SF2, MBOT7. So there are some genetic polymorphisms which make you more prone to, although the phenotype effect may not be 100%, maybe 10% or 20%, but that's a confounding factor to increase the risk of cirrhosis. Some of the environmental factors, obviously the duration and amount of alcohol is most important, but how the patient is drinking, I think binge drinking in adulthood is linked to development of cirrhosis, drinking outside meals. And I think important is, I would like to mention that the coffee consumption, the more observational retrospective studies, even meta-analysis have shown those retrospective observational studies that coffee consumption, especially 4 or more cups a day, is kind of beneficial and prevents you to develop advanced disease in those who are drinkers compared to those who are not coffee drinkers. So this is something I learned as one of the another confounder I think could be discussed and could be proposed is what is environmental toxins causing risk of liver disease. And when I visited here last week, and the center here of environmental toxin associated liver disease at Louisville, and this is picked up this study 2 years ago from the group here from Louisville, which published where a NASH kind of picture was shown in patients who were exposed to certain toxins, for example, volatile organic compounds or pollutants, depending on what kind of industry the patient is having an occupation or exposure. It could be said that patients who are susceptible to NASH because of their metabolic syndrome, toxins may be causing an added, like a confounding factor, like we saw in the earlier slide. But I think I like this, that by itself, toxins are making steatohepatitis or NASH kind of presentation. Actually, the second hit, which we typically see in NASH, becomes the first hit, and toxins causing more inflammation, mitochondrial damage, and metabolic changes in lipid metabolism, glucose metabolism. And then if they are exposed to another risk factor, like a high-fat diet and maybe alcohol, I don't know, that could be proposed, and then they develop steatohepatitis. And this kind of disease, that came with the term called TASH. So now we have NASH, TASH, and maybe TASH, which is toxin-associated steatohepatitis. So coming back to how you gauge the fibrosis risk, the serum markers, which are FIB4 and the APRI score, the easily available, they don't require additional testing. But the problem here is, if you look at their positive predictive value, is about flip of the coin, 50 to 60%. And therefore, if these FIB4 is low, the cutoff is 3.25. If it is below 3.25, then we are fairly certain the patient doesn't have an advanced disease. But if it is above, then you are not very certain. And comes to rescue some more specific tests with a specificity or positive predictive value goes to about 70 to 80%. The ELF test, which is the enhanced liver fibrosis score, the cutoff is 10.5. Fibro test, the cutoff is 0.58. A little more specific test, but then they need additional testing, additional equipment to get those tests done. And they're send-out tests, commercially available. The other thing which you could do in patients where you're not sure, based on, say, for example, easily available routine care of testing like FIB4, which is the most commonly used, is do more commonly available in every liver clinic is elastography, transient elastography, the fibroscan. And the experience on fibroscan in alcohol-associated liver disease is not that high or that great, is still evolving compared to, say, for example, NASH and hepatitis C, where tens of thousands of patients have been studied using elastography. But there is enough. I mean, this meta-analysis of 10 studies on about 1,000 odd patients showed that the linear increase in liver stiffness, so for F1 or above, at a 7, stiffness of 9 or above for F2, and then stiffness of about 12, F3, and cirrhosis at about 18. So somewhere between 12 to 18, you could be quite, suspicious that the patient has advanced disease from alcohol. And I want to give a caution here that an active alcohol use may be a confounder, because inflammation, steatohepatitis may actually give you a falsely high reading, and those things have to be taken into account. And sometimes it may be relevant to repeat the transient elastography after 1 or 2 weeks of abstaining from alcohol, and then repeat, and you may be surprised that the value may come down to somebody who's 12 or 13 may come down to 7 or 8 or 9. So that caution may have to be taken in alcohol-associated liver disease. So summarizing, how do you assess the fibrosis? So if somebody comes with a risk, so if you have somebody already having a cirrhotic stage based on the testing we just saw, then you may want to send that patient to a liver specialist in an accelerated fashion, to not only manage if they have complications, but also rule out alcoholic hepatitis, which you should have a low suspicion for, and then some preventive hepatology, cancer screening, varices screening, vaccination. And then the right patients, when the MELD is over 17, consider liver transplantation. And then if they don't have features of cirrhosis or advanced fibrosis, you do the testing for either FIB4 or using some of the other serum markers. And if they have a low risk of, with the negative predictive value is high, you could monitor them every 3 to 5 years or send them back to the community to control their alcohol use and control the risk factor. But if there is a high risk of fibrosis, you may want to do the fibroscan. Again, if the fibroscan shows below 12, 15, that range, you will monitor them. But if it is high risk, with a fibroscan reading of 12 to 15 or above kilopascals, then you could monitor them as they are cirrhotic, or you could consider using additional testing which are more accurate, like an MR elastography or a liver biopsy. So I think recognizing early disease gives an opportunity to give you a clinical care pathway to not only help the patient, but also yourself in terms of which patients you want to focus on for taking care. So summarizing, screening for alcohol use should be done at every healthcare encounter. I think whenever the patient shows up, either in ER or clinic or anywhere with the primary care, should be done to recognize those who are at risk and then screen for liver disease, and then screen for fibrosis or send them, if they have liver disease, send them to hepatology, and then make a more precise diagnosis of what kind of liver disease they have or how advanced the liver disease is, and then manage accordingly. So now changing gears, moving on to an advanced disease. Again, starting with the case is a more advanced disease of alcoholic hepatitis. The again younger male patient with severe AH, MELD of 34, no cirrhosis on imaging. He's obviously a drinker. Last use was 2 weeks ago. He has no major comorbidities, excellent psychosocial support. He's in a job. He was started on steroids after screening for infections, and he was a non-responder. So this patient ultimately was transplanted, which I think his risk of relapse after, based on everybody's evaluation, was low. So there was a consensus to transplant this patient, which this patient had once he did not respond according to steroids. So I will spend a little bit time, I think, for those who practice, internal medicine or gastroenterology. Hepatologists are pretty aware of these criteria for diagnosis of alcoholic hepatitis without biopsy. So these are the criteria which were given about 5 years ago by the consortia, which Louisville is one of the center part of these consortia for diagnosis of alcoholic hepatitis. In a patient who comes with alcohol-associated liver disease and jaundice, the serum bilirubin 3 or more, liver enzymes typically below 400. So anybody coming in thousands, don't think about alcoholic hepatitis. Then other causes should be focused on. And the AST-ALT ratio is more than 1.5:1. So liver enzymes typically below 400, 500 range, and AST is higher than ALT. Alcohol use typically lasting within the last 2 weeks, 2 months or 8 weeks, and you've ruled out other causes, liver disease and other causes of acute presentation, especially cholangitis, because alcoholic hepatitis could come with systemic inflammatory response syndrome with leukocytosis, fever, and everything. It makes sense to exclude cholangitis and biliary obstruction by appropriate testing before you entertain the diagnosis of alcoholic hepatitis. So if you meet all these criteria, you call it probable alcoholic hepatitis, you could treat these patients as AH and even recruit them in clinical trials. And the clinical trials are enrolling patients based on these criteria. However, if one or more of these criteria are not met, if there is any confounder based on liver enzymes or last alcohol use or testing for other diseases, Then you want to biopsy these patients, looking for typical changes of alcoholic hepatitis, which is ballooning of hepatocytes, neutrophilic infiltration, cholestasis, malariae, and then in more advanced cases, very central hyaline necrosis and fibrosis. So how we manage these patients, whether it is advanced ALD from cirrhosis or alcoholic hepatitis, I think nutrition plays a major role, and the center has a specific interest on nutrition. And so I think it makes sense to talk about that from the patient perspective also. And this, I think, is the best data still holds true after 30 years from the VA on an observation between caloric intake and mortality. And these are all hospitalized patients, and the hospital mortality we're talking about here, somebody who is taking 3,000 and more calories during the hospital, no mortality, almost zero. And somebody less than 1,000 calories, which is 10%, almost everybody dying. And therefore, it comes to recognize those patients who are not consuming enough calories and maybe nutritional supplementation. And how much is worse? And I think this was answered. I mentioned this randomized control trial, although the trial was negative. So the enteral nutrition versus no enteral nutrition was no difference between the groups at 6 months. But when they looked the whole group into the analysis, whether they were, control group or the intervention group, when they combined the whole group and looked at anybody below 21 kilocalories, that's what mattered. Almost two-fold higher mortality with the intake. So typically, and I think we all in clinical practice, whenever we are suspicious about it, we say, get the dietitian on, get the calorie count. 24 hours, you would know if somebody is below 1,200 or so, or 1,500, 12 to 1,500, you consider either supplementing orally or putting an OG tube down, which is a preferential mode of supplementation of nutrition in these patients to improve their outcomes, not only during hospital, but in the long run. So what about medical treatment? Well, corticosteroids, as we all know, is the only available treatment for alcoholic hepatitis and recommended treatment by the organizations. A severe disease needs to be treated, and severity either based on discriminant function score, but of late there are many studies to show the MELD is the preferred score and also the most accurate score, I think, at a cutoff of 21 or above to define a severe disease. And that patient may benefit from corticosteroids if there are no contraindications for its use. But I think this slide also makes an important point that moderate disease, where the MELD is below 21 or DF is below 32, still has a mortality of about probably 9-10% at 28 days, which is a high mortality for any disease. So I think it's been recognized more and more in the clinical trials. One of them completed here of DUR 928 also enrolled patients with moderate disease, and many trials are now enrolling patients with moderate disease. You cannot ignore that population because still have infection. Something I would like to mention here, and patients with alcoholic hepatitis, they're present in about a quarter of these patients, and that's why anybody you're considering steroids, screen them for infections. Anyway, for all alcoholic hepatitis patients who are hospitalized, the infection should be screened for, and those who are not having an active infection can be considered for steroids. And steroids puts them at risk of getting more infections because we all know it puts your immunity down and kind of blocks all the not only the inflammation but also some of the important cytokines which could be relevant in regenerating the liver. And if you put that patient into a condition where there could be a condition of more, if you call it immune paralysis or cytokine storm, you're putting them at risk of nosocomial infections. So you have to use steroids, not only initiate them in the right patient, but also once started, who to continue and who to continue. And how you do that is calculate how the patient is responding at 1 week using what is called as a LIL score. It is a score which goes from 0 to 1, based on several variables at admission and at 1 week. Predominant of that is how the bilirubin has evolved or decreased in response to treatment. And anybody who is non-responder, which is cutoff of 0.5, I think 0.56 here, where you can see the patients who can continue treatment or stop the treatment, there is no difference. Continuing beyond 1 week matters when the responders below 0.5 score. So if there are a non-responder like our patient, it's better to stop the treatment, think of something else to do with the patient. This is a study we recently were part of, which was a large retrospective observational study from multiple centers where we know that there is a lower threshold where the steroids are effective. Is there a higher threshold? That was the question. And in this study, just to give you short the message is that the benefit goes up to from MELD of 21 to 51. But the maximum benefit in the dark blue part, you can see the maximum benefit was between MELD of 25 and 31. So if you want to increase your pre-test probability of who are the right patients to respond, this could be used as kind of a rough, if the patient's MELD is between that range, that's most likely to respond. I come back to the non-invasive test, which I alluded to earlier for diagnosis of alcoholic hepatitis thing. And this is again from the center at Louisville, where the M65, which is K18 cytokeratin, which is not the M30, but the M65 component. 3 controls were used, healthy controls, NASH, and drinkers without disease. And you could see there were levels, and then the alcoholic hepatitis patients at much higher levels of cytokeratin. 18 has not made into practice yet, but I think this is one of the best non-invasive markers we still have, still in research setting. And we did some of the initial studies on mitochondrial respiration, bioenergetics, on a seahorse equipment. As you all know, this is in monocytes, which are purified from a blood sample, and you could use certain modifiers of people who do this technique know of mitochondrial respiration to get various components of the mitochondrial respiration in monocytes. And we enrolled 77 patients, 36 had alcoholic hepatitis based on the NIAAA criteria I showed you earlier. And although the data was all over the place, but mostly the basal respiration and the proton leak associated mitochondrial respiration was much suppressed in patients who had alcoholic hepatitis compared to those who did not have alcoholic hepatitis. And the oxidative burst was much higher overall in alcoholic hepatitis compared to cirrhotic population. When it comes to predicting response to treatment, whether a baseline bioenergetics can tell you who is going to respond, who is not. The sample size was small. We only had 18 treated from 36, and then 12 of these responded. And the baseline bioenergetic response in neutrophils, the oxidative burst was much lower, who ultimately ended up in non-response. So very small sample size. You could see the p-value didn't make it, but there is some proof of concept and some signal there that neutrophilic oxidative burst may be a sign that this patient will not respond to corticosteroid in this interval. Coming to our patient who ultimately got transplanted, we all know that this study 10 years ago showing that liver transplant is beneficial in a very select population of alcoholic hepatitis who don't respond to medical treatment. 77% 6-month survival, 23% 6-month survival who were not transplanted. So clearly they cannot afford to wait 6 months because most of these cases, as you can see, came in the first 6 months. So you have to have an early liver transplant. More and more studies since then have come we have a high level of evidence now to show that there is benefit in that selection. I think the challenge is how to select that population. So I'm showing you all the organizations, ACG, which I think we are currently revising, and in 5 years now. I think Dr. Jaffrin is leading that effort in making the revised guidelines on alcohol-associated liver disease by ACG, and then also EASL and ASLD, showing that recommend early liver transplant in these populations. So I will show you another case here, if we have time to discuss, where I want to show you some challenges we come across when making a decision. And this is again a younger Native American female, severe AH, and this was complicated hepatorenal syndrome. And he did not have a psychosocial profiling, which was as good as the first patient I showed you, as you can see here from the description of the patient. 2 DUIs, court-ordered rehabilitation, lasting only 8 months. She's unmarried, and the boyfriend in the house drinks. So it's not the ideal atmosphere where you can predict sobriety after transplantation. So, and the selection of these patients in practice is based mostly on the psychosocial status of the individual rather than the medical, which is the MED score. Most of these patients would be medically eligible for transplant, but psychosocial status, and this was shown recently with the Accelerate Consortium, that whether the patient is selected for transplant or not is more dependent on their psychosocial status, which is the CPAT score. The SALT score is equivalent of that, which came from the Accelerate Consortium, but CPAT is another one, and that makes more important determination whether the patient would be eligible for transplant or not. So several factors go into scoring, whether you use a SALT score or a CPAT score or a hair score. There are many, many scores available, and I will not go over the list. And these are some of the things you go over the patient, an addiction counselor or hepatologist or the team investigates in terms of risk of relapse. And then you can come up with 3 types of risk. With the low risk of relapse, you clearly list the patient for transplant, like our first patient. High risk of relapse, you reject for listing. And then someone who has an intermediate risk, well, you can tell them to have a rehabilitation treatment first and then list for transplantation. But if they are too sick to comply, like the patient I just showed you, maybe it's difficult for her. MED score is already 39, and maybe whether that patient should go to exception pathway and maybe rehab treatment after the liver transplantation. And that's where the challenge comes, and also the heterogeneity comes in making a decision. One center may be willing, and the other center may not be willing to transplant these patients. And this is why the heterogeneous data, if you look at the US, and this is the UNOS data, I think Tom Carter did an excellent job in publishing this a year ago, where he showed that not only the alcoholic hepatitis transplants are increasing the most compared to other indications, but also it is heterogeneous all across the US in various regions. And in 2019, you could see the 4%, which is the maximum of all the transplants. So it doesn't consume a lot, but 4% of all the transplants in that region would be by alcoholic hepatitis. But you see the other regions are all over the place. Someone not even at all, so 0% of transplants. Huge heterogeneity, but even in the maximum, it consumes about 4%. So if you apply that statistics to hospitalized patients, and this is, I think, Soutar's group from Indiana did a nice study on hospitalized alcoholic hepatitis patients using the NICE database. So in year 2019, there were about 136,000 admissions with alcoholic hepatitis. And if you apply all the population statistics we just saw, who is eligible for steroids, who responds to steroids, and how many do, and how many ultimately end up receiving transplants, you end up still about 100,000 odd people where we do not have effective therapies for them, looking for new therapies. So that makes sense to talk about, and the understanding of the disease has advanced in the last 30 years, especially since I think Dr. McLean has a pioneer in making you understand how the cytokines are important in the pathology of this disease, especially through the gut-liver axis. We already know that there could be a direct damage to the liver through how the alcohol is metabolized and causing mitochondrial damage and oxidative stress. So the drugs could be at the gut-liver axis, anti-inflammation, oxidative stress, and improving the regeneration. So there could be many, many targets. And we'll see what the status is. I'm not going to go into details of these therapies for the sake of time. But what I want to show you here, what I learned last week from the center is another target we normally don't talk about when we discuss the newer therapies, but I think makes sense. We all know that ATP and its derivative cyclic AMP is important for cell survival. And what this, I think Dr. Barve's group did, they took explants of alcoholic hepatitis, the most severe disease, and showed their cyclic AMP levels was much lower compared to those who did not have alcoholic hepatitis, but still ending up getting transplants from other diseases. And on the other side, we know that PED4, which is phosphodiesterase, one of the phosphodiesterases, which is degrader of cyclic AMP, was much higher. So alcohol activates PED4, so there could be a therapeutic target right there when we talk about new drugs for alcoholic hepatitis. What about the current status of the other drugs I showed you in the cartoon? I think, I wouldn't say NASH, even worse than NASH, I think alcohol-associated liver disease, there is an increasing pool of negative trials. Number of trials which have become negative, but there are some hope and promising therapeutic targets, especially interleukin-22, still in phase 2, phase 3. GCSF, the data is insufficient, mostly from Asia. The Western data is mostly negative. DUR, one study from this center, and also currently ongoing phase 3 study. Looking forward to those data, which phase 2 look very exciting. And then fecal microbiota transplant, which not only helps the liver disease, but also there's some data to say that gut liver, but also the gut brain axis, where the changing microbiota might help, and the addiction could be helped by that approach. And that brings us to treating alcohol use disorder in these patients as a second pathology. So just focusing on that and not just focusing on liver is so important. But look at the number here. Just 15 to 25% of patients who need AUD treatment in liver disease patients ultimately end up receiving this. And so clearly we need to promote treating alcohol use disorder in this population. And one of the reasons why such a low amount of or low frequency of treatment in this population for alcohol use, and this is a survey the alcohol-associated liver disease SIG did under the banner of AASLD, and only 50% providers, so almost 50% providers lack knowledge. And this is the survey of hepatologists and gastroenterologists. So they think that they're not comfortable giving pharmacotherapy to these patients. And I think based on this data, we did a small echo project, learning so that hepatologists can learn through an echo model from addiction specialists. I think Loretta was part of that. And we as a group learned a lot, and we are more comfortable in treating alcohol use disorder. And we have an integrated clinic here at South Dakota, which we see patients twice a month and use the things which we learned through this ECHO project in helping these patients. Also, we are supported by the psychiatrists and counselors. So this is my last slide before the summary. And I think more and more centers should promote the integrated care when we have an advanced disease and those who need more severe alcohol use disorder and integrated with addiction team. But I think the integration starts both ways, that if a patient is seen with an early disease, asymptomatic, either in an addiction center, like the first patient I saw, we saw, or in a primary care clinic, they should be with hepatology so that their liver disease could be managed appropriately. And this concept is coming more and more, even in clinical trials. And this was the workshop we recently held at NIH, supported by FDA and AASLD, where I think even the clinical trials are now going to be integrated so that you can focus on both components of the use. So this is the summary of the second half and the summary of the presentation. So there should be a low threshold for alcoholic hepatitis diagnosis. Those who are diagnosed with severe disease should be hospitalized. If eligible for steroids, should be given that. If they are non-responders, should be stopped to reduce the risk of infection and consider the right candidates for early liver transplant. You should not base the decision of early transplant only on the duration of abstinence. Other factors, especially psychosocial criteria, should be more important in making the decision, and promote multidisciplinary integrated care model to help these patients, not only through the transplant, but also the transplantation, and to reduce the risk of relapse and improve the long term. So I'm sorry going over 5 minutes, but thank you very much for everybody's patience and listening. I'm happy to take questions if I left enough time.
Thank you so much, Dr. Singal. I would give it over to Dr. McLean and Dr. Kruger to run question and answer.
Apologize, took us a second to unmute. Thank you very much for that lecture, and it had a lot of good information for management of severe alcoholic hepatitis. A couple of questions at the end. You talked about baclofen and that hardly anybody knows about the use of baclofen. Is it mainly that it suppresses the desire for alcohol? It does cause receptive relaxation in the fundus of the stomach, so we use it a lot for patients with non-specific dyspepsia and motility disorders, and so that's something that general gastroenterologists use and motility specialists use. So tell us a little bit more about baclofen and stopping the desire to drink.
Yeah, I'm glad you brought this baclofen. So a great question, and thank you for asking. I think interestingly, the FDA-approved therapies for alcohol use, like acamprosate or the sulfiram and naltrexone, those are the 3 FDA-approved therapies, are not studied in the population of advanced disease and alcohol-associated liver disease. So baclofen, which is not FDA-approved, surprisingly has been studied the most, and it's pretty safe even in alcoholic hepatitis patients. So we use it a lot, starting with 5 milligram 3 times a day, and then maximum we reach up to 15 to 20 milligram 3 times a day, slowly after every 3-4 days, depending on the tolerance of the patient. The duration of benefit of baclofen for abstinence, kind of in my personal experience, comes that at some time they get tolerance and patients gets back to drinking. The other medication, which I think is also safe and may be used maybe in combination or alone, is gabapentin. We use it a lot. So thank you.
So Dr. Jocelyn has a question in the chat session, and I think I see Tad's hand is up. So we'll go with Dr. Jocelyn really quickly. She wanted to know if a patient has a FibroScan with a score above 75, what is your personal approach to following them up? Do you rescan them, and what is the time frame?
So FibroScan reading shows that the stiffness is 75.
Yeah.
I think this patient is cirrhotic. Even if you abstain, this patient is not going to go below 60, 65. So I would treat this patient as cirrhotic.
As a cirrhotic. Okay. Tad?
Yes, I want to make sure I was not on mute. So one of my other jobs is to provide care to and counseling to sailors in the United States Navy. So, every week, once a weekend or one weekend out of the month, whatever, I'm there, and we have to we have to do extensive counseling. And one of the questions that we ask is, an extensive alcohol use history. And I find a lot of these young sailors some of them are drinking on a regular basis, but tend to keep it, around 2 drinks per day, which is, considered to be safe, although there is no safe intake of alcohol now, I think, as determined by a number of epidemiologic studies. But the subject of binge drinking comes up fairly frequently. And the question, of course, some of these members are drinking 5 to 6 alcoholic beverages in their binge drinking. But the question that I always have is, what is the frequency with which binge drinking can occur where it is probably not going to be deleterious to the liver, and where is that threshold? I think we're much more comfortable with the regular drinking, but not the binge drinking. But obviously from the data you presented, binge drinking is a problem, especially if there are other environmental factors at play, many of which these patients or people dabble in, such as high-fat diet and other environmental toxins being in military environment.
Yeah, to tell you the correct, I think binge drinking is associated with more, as one of the confounding factors. Probably the pattern of drinking is much worse in terms of liver health outcomes. In terms of how frequently, I don't know the answer. I don't think this has been studied in that detail. I wouldn't speculate the answer here, but maybe other people who are experts on comments from others might be useful here. So I wouldn't know, but I know even if you have binge drinking in adulthood or adolescent age, retrospective studies and observational studies have shown that is a risk factor for even in later age development of liver disease and cirrhosis.
Yeah. I mean, obviously, I redirect them to say that you should not be exceeding more than 3 alcoholic drinks in a 20-minute period of time. But that's easier said than done when these young sailors are out there celebrating their, whatever. And I know that the binge drinking is probably a little bit more frequent than what they actually admit to. So that would be definitely something I think that would be helpful to understand the frequency with which people can imbibe, because that is a regular pattern of drinking for many people, especially in the military, and probably additional research.
Right. Well, if I can translate what the question you have to back to the questionnaire we saw on the audit C score, the first 3, how many drinks, how frequently, and on a given occasion, how many. So if we score based on that, and if obviously this person, if it is a binge like once every 2 months, maybe scoring less versus binging, say, every 2 weeks, maybe scoring more. So certainly if you use that model based on the number of score correlating with the risky behavior, maybe that may be helpful. But in terms of at what cutoff the binging is more deleterious, I don't think so.
Yeah, so Tad, binge drinking is defined as in men 5 drinks in 2 hours. And so it's not only a risk of liver injury, but it's a risk, obviously, of driving or other things. But if you do it more than 2 times a week, why, then you're more at risk for liver disease.
Okay, thank you. That's perfect. Perfect.
Dr. Williams.
Well, yes, this was really fantastic. And it was a great, as you said, it was going to be a good clinical introduction for those of us who don't, measure those levels of things that are going to predict. But my job is always to look at the ethnic disparities. And this is one where years ago, it became clear that people of color were not getting as much transplant. But regardless of our difficulty with Hep C and the African-American community, Hispanics have this issue that I never quite understood. Why do Hispanic people have so much more alcoholic liver disease? That VA study saying giving levels that were so much higher than whites. Is it something genetic? Is it the diet? What is it that? And then of course they're getting less transplants.
Right. And you brought up the right point, Dr. Williams, and there are disparities in terms of not only the transplant, as you mentioned, but also development of liver disease from alcohol. For example, Native American population here we see all the time are more prone because of because of surroundings and the availability of alcohol. And I think the way the alcohol is consumed, I think maybe, I don't know whether that is the reason for Hispanics being more likely to get alcoholic hepatitis or more frequently getting alcoholic hepatitis. That's a observation which we also made recently using hospital data, the transplant data, that Hispanics and Native Americans are more likely to develop the disease. Blacks and African Americans are less likely to get the disease, but once they get it, they're less likely to get a transplant. You rightly said. There was a VA study almost 20 years ago, and I think it still holds true, where they looked at the predictors of not referring an ALD patient for transplantation. So the two major predictors which came for not ALD patient, for any cirrhosis patient for transplantation, and the two major predictors which came was a diagnosis of alcohol associated liver disease in the chart, and this was a chart review based study from the VA, and African American ethnicity not being. So I think there are some barriers there, and yeah, those should be.
It always looked like there were a lot of barriers, but the fairness of the liver programs was very clear. That it doesn't matter what your ethnicity is. Once you're listed, you can get a transplant regardless. It's just getting recognized, getting diagnosed, and then getting in. That seems to be the barrier. But then, I'm hoping that we can come up with why it is, and I imagine it has to do with nutrition in the Hispanic community, but that's speculation on my part.
Yeah. So a couple quick things to put a plug in. We're talking about new drugs for alcohol-associated hepatitis. We do have the DUR 928 study here at University of Louisville right now. So you can contact Matt Cave or myself if you have a patient, and this looks like a magical new drug. The other thing, we're putting on a liver conference March 4th. And because we have a great new chairman of medicine, why we're cutting him a deal where all the house officers or anybody associated with the School of Medicine can get in with no tuition. So we'll put out information on that.
Fantastic.
Thank you.
There were a lot more questions, but the time has gone on. There were some questions about genetics, and of course your individual P450 has a lot to do with susceptibility. There were questions about microbiota. So it's great to see all these people interested in alcoholic liver disease and ameliorating it. But now we're going to have to move on and let people go to clinics. And want to thank you, Dr. Singal, very much for bringing this lecture, and particularly that you made it case-based. I think case-based presentations stick with the residents.
Yeah.
So.
Thank you.
All right. And thank you, Dr. Singal. Thank you, Dr. Kruger, Dr. Mark McLean, for facilitating another great Redinger lecture. And Dr. Williams, thank you for everything as always. And before you go, two things before you go. We do have a tradition here at the University of Louisville for our guest speakers for grand rounds, and especially for our endowed talks, of a special gift that is very synonymous with the university with the city of Louisville. So you will be receiving your very own Louisville Slugger bat.
Thank you.
With we'll have that with engraved and everything, and so I'll get in touch with you about that. And one more thing we want to do, we're going to wrap this up, and we do a thing called the Cardinal Minute, which is just a quick thing with Dr. Williams and yourself, where you do kind of a 60 to 90 second summation of your talk, and then we'll put that on our Twitter, of course, tag you and our website. So what we're going to do is when we close this out, I'm going to close the meeting in a moment, and then if you can come back in the same link, and it'll just be Dr. Williams, myself, and you, and we'll do that. We'll knock that out. Shouldn't take more than a couple of minutes.
Okay.
It'll actually be Dr. Kruger.
Oh, Dr. Kruger's doing the Cardinal Minute.
How about that?
Cool. Okay. So Dr. Kruger, we will do that. Same thing. Just
So right after, or?
Yeah, well,
Right.
I'm gonna, I'm gonna close the meeting here in a moment, and then you and Dr. Kruger just patch back in, and we'll get that taken care of. So, and just want to let everybody know we'll be back next week. It'll be our annual visit from the Department of Neurology, Dr. Robert Friedland, who has spoken before on some very pertinent subjects, kind of bridging between neurology and internal medicine. Will be presenting. So look forward to that, and that'll be next Thursday at 8. So thank you, everybody, and thank you, Dr. Singal, and all the folks in GI, and we'll talk to you soon.
Okay. Thank you.